Uh, Good afternoon, everybody. It gives me great pleasure to introduce Dr. VJ Purushotham. Dr. VJ Purushotham is Professor of Orthopedics at BMC Bangalore. He is a very senior orthopedician with more than 32 years of practicing experience. Dr. Purushotham, has done his post-graduation from KMC Bangalore, and he's also had very important positions like he has been the past president of Karnataka Orthopedic Association also. I'll make this very short and ask Dr. Purushotham to take over. Before we do that, we have muted all your mics. Any questions can be put in the question answer box, which Dr. Purushotham will be answering at the end of the session. No need of putting questions in the chat box. Please put in the question answer box the questions. Over to Dr. Purushotham. Doctor, please take over.
Thank you, Mr. Vasant, for that introduction of mine. And good evening to all of you. Welcome to this CME on low back pain and sciatica. Hope you all had a good day with your practice or staying home, enjoying this COVID lockdown or whatever you are doing all these days of 2 months, nearly 2 months. Well, I've been given this topic that is quite close to my heart in my practice of 30 plus years, which has not changed significantly in the last 30 years. So let me begin with the question why this topic has been taken. We all know with the insurge of this COVID era in our surgical happenings, we are moving towards more and more non-invasive or less invasive treatment preferred. And what better topic than spine? Because in my experience, largely I have this experience of conservative management of low back ache. And I think this time and in the coming times, the treatment of low back ache has to be more of conservative, where I feel and I have strongly vouched for in my experience 30 years. As usual, to begin with any of the topics, let's have a brief anatomy of spine. I'm not going to bore you with the entire anatomy of the back because you are all aware of this. I hope there are some orthopedic surgeons also. I'm told it is largely of physician, diabetologists and gynecologists, and some general practitioners also. And there are some orthopedic surgeons. I know most of you are familiar with the anatomy. I'm only going to tell about the motion segment of the spine. What do we mean by this motion segment? Two vertebrae, like you see here. I hope you're all able to see the screen. And the two vertebrae and the intervening intervertebral disc, what you see here in the purple color. And this is the spinal cord and exiting nerve roots. This two and one vertebra makes this as one segment of the motion, that is motion segment of spine, which is supported by strong ligaments like anterior longitudinal ligament and posterior longitudinal ligament, which is here, and supported by these ligaments, and of course the back muscle, what we all know about. Most important muscle is where we get to see that typical spasm. The patient comes with pain and spasm on the back. That is this erector spinae muscle, which is over here. So this is briefly about anatomy of the back. More precisely, when you go to the disc, which is in question of low back ache, or for that matter, sciatica, it is the shock absorber. We can, in general term, we can call it as shock absorber of the spine. That is, it is cushioned between the two vertebrae, takes the load of the axial load of the spine and the body and distributes the load, and also helps in the movement of the spine. So that is the primary function of the disc. A disc is largely avascular. What you see here is the stronger outer layer, that is annulus fibrosis. It's a fibrous cartilage, and the nucleus pulposus, which is the gel material, which is in question always when disc is ruptured or herniated, protruded or sequestrated, which I'm going to show in the Next slide. So disc lesions, I think it is quite common whether you are a physician or a diabetologist or orthopedic surgeon. The patient walks in more often, the so-called software engineers or some learned patients, when they say, doctor, I have disc. Yes, they walking like that. I have this, like how they come with, I have appendix, or I have BP, or I have sugar, like that. So the main concern of there is whether the disc is of normal texture, which I just showed in the last picture, which contains in its geometry between the two vertebra in its equal depth. When it is degenerated, it loses its tensile force, it becomes weak, and it is thinned out. That is what we call disc degeneration. It's an age-related process. For example, in the second or third decade, up to third decade, or in the early fourth decade, you can see a normal disc. Later on, as you go from fourth to fifth, sixth decades, you will see the disc degeneration. And that is the reason we get to see many backaches related to that. Now, interestingly, this degeneration can lead to prolapse when the nucleus pulposus, the gel-like material, seeps out and compresses or pressurizes on the nerve root or the spinal cord. When further prolapse of this nucleus material will lead to extrusion, that is where we call herniated disc. A simple bulge is what we see here in the right side of the picture. I would like to go on the record to say bulging disc is a very common phenomenon that is followed always by the degenerated disc. For example, we have done a study a few years back where we took MRIs of some normal spine, that is normal in the sense a symptomatic patient who has not complained of any pain or discomfort. Even he or she had in his MRI finding a bulged disc. That means to say a bulged disc is something like normal, that is possible or present in the later stages of our age. Extrusion is the extreme steps of prolapse, and the final state of the disc lesion is when the complete extruded material goes out and separates from its main body. Then it gets like sequestrated. We call it a sequestration of the disc. I hope you understand the disc lesion clearly now. And this is what is the primary cause of these pains when we talk about, other than the muscle strain or muscle sprain, I mean ligament sprain, what we get to see in the back. So that is as much for the disc lesion. Let's go to our main topic now, having gone to the anatomy of the back and the disc. The low back pain and sciatica is the topic we have chosen here. Now, low back pain is defined as pain and discomfort localized below the costal margin, that is just below the rib cage and up to the pelvis. That is what we define. Even the patients describe similarly, like when they say low back, they say, no doctor, not this, this is the position, the portion of their back that is painful. And when the patient comes with a complaint of low back pain, it has to be either acute or chronic. Acute is following sudden impact or an incident of lifting weight or traveling or some injury, or maybe because of the trauma, they may come with acute low back. But chronic low back pain is one which is defined as the pain persisting for at least 12 weeks as per the evidence or as documented in the literature or the textbook. But in my experience, I call all the low back pain, which is more than 6 weeks time, yes, chronic low back, because an acute low back has to settle within 2 to 3 weeks. So anything more than 6 weeks has to be chronic low back pain. Now, what is this sciatica? It's a term used to describe the symptoms of low back pain that spreads, radiates through the hip to the back of the thigh and down the inside of the back of the leg via the sciatic nerve. What you have to understand here, the course of this pain, how it traverses from the back to the back of the leg or even to the ankle or foot, that is, it is the course of the sciatic nerve. It may be characterized by pain pain is the main one. There may be tingling, numbness, or weakness. Excuse me. Sciatica is not a diagnosis. Sciatica is a description of symptoms of inflammation or compression of the sciatic nerve and not a diagnosis. So the topic here is low back pain, whether it is acute or chronic, whether it has the symptom, main symptom of sciatica. So I hope you understood this point. So this is what I was trying to tell you in the previous slide. You can see the course of this sciatic nerve, which originates from lumbar and sacral plexus, goes down, bifurcates into two branches, and goes down. Mainly, it traverses behind, and that is the posterior aspect of the thigh and leg. And this is the sciatic foramen where it goes down, and the exiting to the thigh and leg from proximal part of the femoral region. So the typical pain, the sciatica has to be this only. There are certain other pain which can traverse through the back, that is through the gluteal region, upper thigh, that may be sacroiliac joint or something, coccydynia or something related to that. But sciatic pain is the one which courses through the sciatic nerve. Now, coming to the prevalence of low backache. In the literature, or you look into any evidence, it says 50% of all adults have low back pain every year. If you take one Miss McNabb, who is supposed to be the pioneer in back pain and back surgery from Canada, late, he's no more, and according to him, 90% of population would have suffered low backache at one point of their lifetime, according to one study they have conducted. So the prevalence could be as high as 90%, but we can take it as 50% of adults will have. So that is so huge, but 15 to 20% seek medical, only 15 to 20% seek medical attention for the same reason of that backache. So in Western world, like in North America and Europe, it is one of the major causes of disability for younger patient, population that is below 45 years of age. But here in India, our endurance is much better than the Western population. So probably we are not up to that extent of seeking disability compensation or something like that, workman compensation, what I meant. So let's go to the causes of this pain, which either stays back in the low back or has a symptom of sciatica which runs down. It could be sprain of the ligament. Usually sprain is related to the ligament, whether it's pulled across, whether it's torn, or strained muscles like back muscle. It is possible, like awkward movement, sudden movement can cause sprain of the ligament, or the one I showed in the anatomy picture, or the muscle getting strained. More importantly, it is always because of the degenerated disc lesions, herniated, protruded, or sequestrated, which we just saw. Another important reason of low backache is spinal stenosis, where the spinal canal narrows down. The canal is constricted owing to several reasons, which I'm going to tell in another slide. It could be degenerative arthritis like spondylitis or facet joint arthritis. Facet joint arthritis is most common of the degenerative diseases because the facet joints are the articulating joints of the vertebra, bone to bone, and it's a synovial joint, and it pivots around all movements of the spine, and that is the reason it gets into malalignment and arthritis and major cause of backache. Spondylolisthesis, which means slipping of vertebra, one vertebra over another vertebra, or it could be sacroiliac joint arthritis, which I mentioned, could be little lower down than the back, which we all spoke about. Ankylosing spondylitis is another cause for low backache. It's an inflammatory condition which we describe as bamboo spine, where the fusion of the spine occurs, or hip, both hip and ankle. And this is inflammatory condition. So friends, it is, if you look into this aspect of causes of pain in lower back, I would say the main causes could be divided into mechanical, or inflammatory. So mechanical causes are nothing but related to the sprain, strain, or disc lesion or arthritis, or the inflammatory one like sacroiliac joint arthritis, ankylosing spondylitis, or infection, which I'm going to show in the last slide. So most of the backache which turn up to our clinic or your clinic for presentation of back pain and disability resulting from that, majority of them related to mechanical cause. It could be also be deformities if there is a congenital or acquired deformity like kyphosis, which is forward bending of the spine, a lump in the back, scoliosis, which is side bending of the spine, lordosis, backward bending of the spine. These are the deformities which could be present, and osteoporosis, weakening of the bone density is reduced, and emotional stress is one of the significant reasons of psychosomatic pain cause of the back. And we know these three are the red flags, that is acute pain causes, that is vertebral body fractures, definitely back pain will be there with a history of trauma, fall from height or road traffic accident, infection like osteomyelitis or abscess of the disc, whatever can cause pain again. And again, tumors, multiple myeloma, there are hemangioma, there are plenty of tumors related to spine, osteoblastoma, these are all common in the spine. So these are the tumors which can get to be seen in the spine, and these are all totally put together as the causatives of pain in the lower back and extremities. When I say extremities, it's sciatica, radiculopathy. Now, we'll go to the important causative factors of the sciatica or radiculopathy. We know that back pain is the syndrome, the condition we are discussing here. The symptom is the radiculopathy or the sciatica, and the most often and majority of the causes, disc herniation, we discussed just about it. You can see the picture here in this slide where the herniated disc is, this is the disc, and herniation can be seen here very clearly. It is compressing on the cord itself here, or the nerve root, what you can see here. And most commonly that happens in the L4, L5 disc space or L5S1. Why? Why this L4, L5 and L5S1? We know the different types of movement occurs in our spine. Most mobile segment of our spine is cervical spine, where there is flexion, extension, rotation, lateral bending. All the movement can happen in cervical spine. Whereas thoracic has limited movement, majority mainly of forward flexion and little bit of extension, but lumbar spine is next only to cervical, has the highest range of movement. Complete range of, near complete range of forward flexion, that is bending forward, or backward extension happens in the spine, little bit of rotation. And the spine, lumbar spine is most weak at the region of L3, 4, 5, S1, for the reason the posterior longitudinal ligament, by virtue of it is itself is weaker than the anterior longitudinal ligament, which is in the front. The posterior longitudinal ligament is in the back. So that gets weaker as it goes down, and as the degeneration happens, it is much weaker, and the degenerated disc is also weaker at the given point of the time. If there is a stress on this two part, it gets herniated. So that's all about herniation. We discussed
Doctor?
Can you see now? Yeah, from yeah, I'm taking it. Yeah, did you see now? Okay, this is a bit slow here. Yeah, did you get this now? Okay. Sorry for the interruption. I think there was some technical error of zooming of my. I think I'm going to repeat again. Disc herniation is the primary cause of uh, low backache, and more often it happens in L4, L5 and L5, S1 because posterior longitudinal ligament is weaker there, and it is the mobile part of the segment of the lumbar spine. So degenerated disc added upon the posterior longitudinal ligament being weak, it causes the forward and backward herniation that happens like protrusion or extrusion or sequestration of the disc causing the constriction. Next one we talk about, I hope you're all seeing the screen, the spinal stenosis, where the canal is narrowed here. The reason could be many, like degenerative arthritis or facet joint arthritis, where it constricts the spinal canal. The diameter of the spinal canal is narrowed down, and it presses or pressurizes on the spinal cord or the exiting nerve roots. Spondylolisthesis, as we discussed, is one of the degenerative causes which is possible is spondylolisthesis, where forward slipping, like the top one slips forward, that is, we call it as L4 slipping over the L5. This is the exact description of this diagram. It's not this going back, this going front. That is the spondylolisthesis. There is another condition where we call retrolisthesis, where this goes back, but the spondylolisthesis is the most common one. And again, it happens most commonly in L4, 5, S1 segments. Right. Hope you are clear about these three conditions. This is one of the most commonest causes of backache, facet joint. We know that the intervertebral articulating joints are superior and inferior facet of the superior vertebra, superior facet of the inferior vertebra articulate here, and they are called as facet joint. And owing to the degeneration, they may get misaligned, or because of the stress and strain and this bony spurs or osteophytes will press upon the exiting nerve root, like the most common cause of the backache. So these three are the more important or most important causes of the backache, mechanical causes. And other causes could be anything of the inflammatory conditions, what I told, like tumors, or because of the muscle strain or something like that. One important syndrome which is always diagnosed by the new spine surgeons of this era is pyriformis syndrome. Pyriformis syndrome is nothing but typical in its presentation like sciatica, starting from the hip, traveling down to the thigh, back of the leg, and into the foot and ankle. So this piriformis syndrome is attributed to sports injury, where the piriformis gets into spasm and it compresses on the sciatic nerve, and that could lead to the irritation of the sciatic nerve in course of some movements. There is a reason attributed to pyriformis syndrome of late, like carrying heavy wallet on your back, because it has been seen, other than athletes or sports individuals, it has been seen in men who carry heavy wallets in their hip pockets, and that causing pyriformis spasm and resulting in that. And sciatica can also, it's one of the most common symptoms we get to see during pregnancy because of the irritation of the sciatic nerve owing to the pressure on that part of the body. So friends, now we have briefly looked into the anatomy, the causative factors, and what is typically this disc lesion, and what are the other types of mechanical obstructions like listhesis or canal stenosis or facet joint arthritis. Now, as usual, if you look into the history of taking any of the conditions when we get to know, the history of low back pain is not very different. We usually ask when did, like the question like when did the pain begin, what precipitated it, was there an injury, because we have to rule out acute cause of the injury, or did it happen spontaneously like while traveling or while doing some work, or because of prolonged sitting, which is very common in these days of present generation. Does it stay? Very important question you have to ask is, does it stay in the back or does it travel? This is where we differentiate whether it's a simple or low back which stays in the back, or does, if it is a radiculopathy, which is sciatica, which travels down the hip, the thigh, and the ankle. And also what makes the pain better and what makes it worse. For example, we all know that forward bending is dangerous, but in conditions like spinal canal stenosis, forward bending relaxes, releases, and the patient gets some relief of pain. We call it as, shopping cart sign. When the patient bends forward to push the cart, he gets some relief, bending forward, the walking downhill or something like that is the, and is there any weakness associated with this? Very important, because we cannot wait when there is weakness, and especially the weakness is progressing. And biggest red flag or the problem that we have to immediately attend is if there is any loss of bowel or bladder control. If this is there, then a condition called cauda-equina syndrome. Cauda-equina is the end of the spinal cord, as we all know, after the conus medullaris, which stops at, it begins at around T12, T11, T12 vertebra. Conus medullaris narrows down and shoots out nerve roots, the cauda equina we call, from L1, end of the L1 vertebra. So if that is involved, then that rings bell that we have to attend immediately, and there may be it may be a case for surgical intervention or further probing. Clinical pictures, definitely pain is the most common symptom of backache. And in sciatica, we discussed it radiates down the leg, down the thigh, typical of that nerve's course. Numbness or tingling sensation or irritation. Any of these three can be a root cause, irritation of the roots, the nerve roots causing these symptoms. And if it is significant, there would be some walking difficulty. Patient says there is some weakness in his lower limb, maybe in the ankle or in the knee joint, and the difficulty in walking. So the radicular symptoms are increased with forward flexion, sitting, prolonged sitting, I must say, driving in car because you're sitting constantly and attending to steering, and if it is a geared car, applying gears, cough, sneeze, and bowel movement, it can increase the radicular symptoms. And it get decreased in a lying supine position or when the knees are flexed. So this is a picture to differentiate between a radiculopathy and claudication. Claudication is a typical symptom of spinal canal stenosis. So it happens only on standing and walking, whereas radiculopathy is present continuously, whether patient does any other work or only while lying down, he gets some relief. So this is exactly the pinched nerve root in radiating pain, whereas in spinal canal stenosis, this is what it happens, spurs or growths of the canal. Examination, nothing great about examination of the spine, just you have to look for the tenderness. If there is any acute trauma related to the spine, we press on the spinous process and paravertebral muscle. More important, I get to see in my patients, a lot of my patients will have spasm, paravertebral muscle spasm, when you compare it to the other muscles, little above the complaining area, you will get to see that muscle is relaxed or it is not tense, whereas this portion where he is complaining is that. So that is the typical of. And further, we have doubt about the pain radiating down, then you have to do a test called straight leg raise, SLRT we call, straight leg raising test, described by French physician Lasègue. And it's very helpful. In my last 30 years, I have not seen this test has been changed at all. And very informative also. I do for all backache, even without radiculopathy also, to rule out, because patient may not be in a condition to express his exact situation. So this is how it is done. Patient is made to lie supine on the table. It is a passive test usually, as described by Lasègue. You have to start lifting the leg straight, and when the patient gets the pain, it is noted that he has pain in that amount of degree of raising. Please remember, this pain is caused because of the stretching of the L5 and S1 roots, and this will happen only after 30 to 35 degree of movement of the leg. I have seen in my practice some patients, the moment I put my hand and start moving the leg, they are telling you it's pain. Either they're malingering, you should remember. If that is then you have to doubly sure and cross-check with other limb also. They may have similar symptom in other limb also. But it may be also sometimes so severe that you may get SLRT as low as 10 degree. But generally, it is understood Lasègue test is positive, that is straight leg raising test is positive only after raising 30 to 35 degree. And one important aspect of this test is when the patient has severe pain, you try to flex the knee. We call it as bowstring effect. When you press it, when you flex it down, patient gets a lot of relief. So that is again a very confirmative test of the stretching of L5, S1 or L4 roots. And we have to do neurological examination. If the SLRT is positive, definitely we have to rule out distal neurological involvement like ankle reflexes, knee reflexes, and also the testing of the light touch sensation. You can take a wisp of cotton or some substance in your hand and look for the sensation comparing to the other limb. As we know, the medial side is, in this picture you can clearly see, the medial side is L4, the dorsal one is L5, and the lateral one, what you see here, is S1. So these are the typical narrow root segments, zones of this sensation, which you can decide. Now coming to the investigations. You can see in this screen, there are a battery of investigations to carry on in the backache. But the question here is, do we need all these investigations? My answer is no, absolutely. I don't write any investigation when the patient comes to my clinic, unless it is an acute. Even in acute, sometimes, most of the times, acute condition also, I just examine, I undertake all the examination what I have mentioned. If there are no red signs or red flags, what I'm going to show in one of the slides later on, then I put him on my mode of regime of treatment and never ask for anything, any of these investigations. Plenty of investigation, what you can see. Discogram is totally out now, nobody is doing. Many of them do. I think I have seen many of the surgeons or practicing orthopedic surgeons or some other field or writing for MRI. I've seen some physiotherapists also writing for MRIs the moment patient goes to them directly with the backache, which is absolutely wrong and abusive. Never write MRI at the first instance of patient turning up to you for backache or even sciatica, for the reason I'm going to tell further. I told you, we have done a study where we have done a group of normal, that is asymptomatic patients also without any symptoms in the back, are also having disc bulge. So if you take an MRI of yours or mine at this point, I do have a little backache, but though, you get to see disc bulge in most of the films. It's absolutely impossible or very, very rare you get an MRI reading saying the disc is perfectly normal. Please understand this point. So that is the reason never ask for. But unfortunately, at times you may face with a situation when the patient demands. There are situations in the jet set age of this era, the software profession, I'm not categorically, with due respect to their profession, I'm telling, because they are in hurry and they want everything to be done fast. So I have a sizable portion of such patients coming in the area where I practice, and they are, sir, can you do an MRI for me, please? I usually joke, why you want to donate some 5, 6, 7,000 to the lab? You can go ahead and get it done. But in my opinion, no. But if they, but please remember, and also you also know, I think, there is a point called psychological therapy. So to treat them psychologically, what I do is, if they are asking on their own, then only I write for X-ray. Truly, X-ray may be little more informative in those circumstances, because we get to see all, whether it is muscle strain or ligament strain or facet arthritis or spondylitis, or for that matter sciatica from the disc. You will see the paravertebral muscles spasm, which will be clearly seen in X-ray, like straightening of the spine. Normally, the lumbar lordosis will be curved like this, isn't it? That curve is lost, it will be straight. So that is one of the significant findings we get to see in the X-ray. But it doesn't help in my treatment at all. But to treat them psychologically, I would order for an for an X-ray. Excuse me. So, 1 minute. Bone density test has taken a lot of interest in among the practitioners. Of course, it is helpful in a certain extent, but at the drop of the hat, when the patient turns to your clinic and consultation chamber, you don't have to order for bone density test at all. How it is going to help, I don't know. But do you want to look into the osteoporosis, which is important? So I will say when to order radiological evaluation LPP. This is my protocol. That is why the topic is my experience. Maybe the evidence or the literature may differ with what I am trying to tell, but most of the evidence is literature support, and most of my friends who are designated, dedicated spine surgeons also agree with these things. Definitely trauma, we have to do X-ray to rule out. And if he is over 50 years and we suspect that 50 to 55, 60 years, and we suspect that there may be some important spondylitic changes like spurs or osteophytes, then we may order. Or patient, very elderly patient, definitely I ask like 70, 80 to look into the degree of osteoporosis. Then if I am confirmed with that, then I may ask for bone densitometry. And definitely the red flags, what I'm going to tell in my one of my slides, definitely I'll ask for. But does that mean that you will never ask MRI? No, absolutely no. I see, in my practice, 30 to 40% of the patients are spine patients, low backache patients. Truly, out of 10 patients, 3 or 4 will be low backache every day in my consultation, private consultation. In my Bowring Hospital, that is teaching hospital of Bangalore Medical College, I think definitely the ratio is same, 30 to 40 or 30 to 40% of the patient turn up with acute or chronic low backache. All of us, my colleagues, or most of us, do not order X-ray or MRI immediately in those circumstances also. But we have to order. We cannot sit on that for long. So should we wait till 3 months? No. What I meant is, if the symptoms exaggerate, like he comes today with the pain is increasing tomorrow, day after tomorrow, you try other medication, try other physio, but then it is increasing, and importantly, the weakness is also progressive, then do not wait. You have to definitely look for further investigation. More useful is MRI evaluation. And in conservative management, my protocol is to wait up to 6 weeks. Up to 6 weeks, I treat him. If he has got relatively good relief, I won't say 100% relief. He has about 75 to 80% relief. And if I put him on good core stability exercises, I'm happy with that. I will not ask for MRI. But if even after 6 weeks, if the patient continues to whine with pain and keeps complaining, keeps coming back to me, definitely I have to look for further investigation. That is, MRI is the only investigation I have to look. Of course, if I look into inflammatory condition, I may have to rule out with other investigations also. And definitely the red flag sign like bowel and bladder involvement, which is caudate venous syndrome. We cannot sit tight. We have to order for MRI and rule out the cause of that pain. So this is the picture what you get to see here. It is almost normal. Like I said, see, these are all bulging of the disc, which is very common. Maybe a little bit of protrusion here between L4 and L5. And it's the most helpful one when we have lost significant time of investigation. Or I'm sorry that my film of X-ray is losing. X-ray is quite useful in knowing the spondylitis, spondylitic changes, paravertebral spasm, where the spine is flattened, it is straight other than usual. I'm sorry, I don't have that picture here. I had it, I think I have missed it while mixing it up now. And CT scan is not of any use. Myelogram is not really done these days with a good image from MRI, good resolution MRI. Nowadays we have 3 Tesla MRIs also. The information we get in those MRIs are much, much better than what we get in CT or in myelogram. So CT and myelogram are not required. Of course, CT might help over MRI if there is a cause of some inflammation like tuberculosis is cause of the pain, or infection like tuberculosis, what I said, or tumor, something like that. Then you want to really see the structure of the bone, then you may require to do CT scanning complemented with the MRI. Let's just look into the risk factors, because without knowing the risk factor, it is impossible for you to treat the backache. Age, we discussed, older the age because of the degeneration, and also the spondylitic changes. Obesity is one of the causes. An individual who is overweight or obese will definitely have backache, one of the symptoms other than what he has. Diabetes is one of the causes. We do not know what is the root cause of this virus, but I've seen in my practice, most diabetes patients who do have backache. Occupation, definitely a job that requires you to twist your back, carry heavy loads, drive for longer hours. All these patients, these are all the segment of patients who come to me with backache. And I'll tell you, I told you that the riskiest movement is bending forward and suddenly rotating. Rotation, this lumbar spine cannot take. So when you have bent, the lumbar spine is moved to the maximum level. And when you start rotating to pick up, it usually happens with youngsters or middle-aged individuals when they are bending forward and then try to pick up something and they rotate suddenly and they come in the morning next evening saying that what happened. Pregnancy, of course, owing to the increase of weight and pressure of the uterus. Prolonged sitting, this is an interesting point, that prolonged periods of sedentary lifestyle are more likely to develop backache and sciatica. Look at this picture. This is the typical postures which will have stresses on the back in different positions. I would say the side sleeping one, the least one, I don't know, this is taken from some textbook. Lying on the back is least, it says, but my experience and my understanding and my thinking is this goes down here, this comes here, standing next, sitting continuously, bending forward, slouching. I would say this is one of the worst posture that one can adopt to give rise to backache. We see a lot of youngsters slouched on the couches, watching TVs hours together, even students reading style, even in the office also we have seen wherever I go to take classes on ergonomics on backache in offices, I see, I ask them to raise hand how many of them sit in such position, and I get to see many of them raising their hand. So slouching is one of the worst reasons of getting backache. Bending forward and lifting weight, and the worst is the red sign is where you slouch and lift weight. That is the worst thing to have. Now we'll come to the last part of this topic, that is treatment. So this cartoon is very depictful of my treatment prescription. Obviously he is a bit overweight and he is carrying loads of weight on his back. So his prescription would be from this doctor is go for digital textbooks. Of course, I would rather say put down your weight, reduce your weight. In my experience, and in most of the evidences, and most of my friends, spine surgeons, agree that 90% of simple backaches and 70 to 80% of the sciatica settles within 6 and maximum 12 weeks. With your simple treatment, it settles. Only 2 to 3% of backaches and less than 10%. In my experience, less than 5% of sciatica and less than 2 to 3% of simple backaches without radiculopathy will require surgery or some intervention. So that means have patience while treating backaches. That doesn't mean you wait, you send the patient back, come after 6 weeks. No, no, no. That is not what I am going to tell. We have to give him pain relief, him or her, isn't it? The best pain relief I have seen is with the non-steroidal anti-inflammatory drugs, whichever suits the patient. I usually give proton pump inhibit PPIs like Pantocid or Rabiprazole or whichever is suitable to the patient. I usually give extended release tablets once a day because he naturally he will have osteoporosis and other conditions. So combining too many drugs will be, and asking him to take twice or thrice a day will be too much of an asking for a patient with, and he will lose interest in a couple of days, and that may be one of the reasons he may come back and tell no relief. Topical applicants, the reason here why I'm stressing on this point is, in my experience, though evidence says no to this, in my experience, topical applicants, gels and sprays, I don't recommend sprays, gels and applicants, by virtue of their counter-irritant property, they do give some good feel-good relief and also some temporary relief from the pain. We are looking at pain relief here. Narcotics, what I meant is not high-end narcotics like codeine or morphine. We are talking about simple tramadol. Tramadol is a good molecule which can be given for simple pain relief. Of course, we have to give it with caution, like nausea, vomiting, which may be common in female. I avoid these tramadol in female patients. Muscle relaxant is always I have to put on them, because in my examination, 90% of backache patient would have the spasm of the paravertebral muscles, and muscle relaxants like, more importantly, thiocolchicoside, which is more helpful in relaxing the muscle spasm. And one of the very important prescription range of my drug is pregabalin. I don't use gabapentin. I use pregabalin, one of the vitamin B derivatives, along with vitamin B12 methylcobalamin. I don't know how this pregabalin works here. I think this pain is not just a nociceptive pain, what happens in trauma or other injuries. This is a neuropathic pain. So pregabalin is best, like Neurator or whatever brand name it is available, which is quite useful. I invariably I don't put it on the first day of their appearance. I wait for 1 week or 7 days, 8 days or 10 days. If they are not getting relief even after 2 weeks, then I put them on pregabalin. Antidepressants I rarely use, very rarely use, but most of the surgeons do use, because the psychosomatic relationship is much more with low back. Physiotherapy, core stability exercises. Remember, the back muscles are the protectors of the spine, stabilizers of the spine, and their exercise, strengthening them, is most important. Physiotherapy is morely on that, not about IFTS, shortwave diathermy, ultrasound massage, or laser. These are all temporary ones. I would prefer the old traditional shortwave diathermy, which affects the larger area and gives good relief. I would recommend that for an acute pain. For a chronic one, core stability exercises, which I'm going to show in my last slide, is more than it. What about these now? Very interestingly, because none of the spine surgeons will advocate it, and evidence says no. They say don't use this. In fact, they say it weakens the spinal muscle and it is derogatory and it has adverse results. I have stopped using this traction. This is pelvic traction. which was rampantly used when I was a student, postgraduate student from a few years back. But last 15 years, I have not been using this. Even I don't think it even helps in any psychological relief also. But I do use this belt, lumbar corset, a good made, well made, perfectly fitting. But it has to be used only sparingly because patients has the tendency to get addicted to lumbosacral corsets. So caution them, they have to do their spinal extension exercises, keep the muscle in condition, then wear it while at work or while sitting it for a long time, and where the work demands sudden bending forward or rotation. So in that limited orthotics usage, I recommend. Injections, I used to give a lot of epidural steroid injection. It gives tremendous result, but temporary. You may have to repeat it, and mind it, it's a steroid injection, so you may have to repeat. ESI is nothing but steroid infiltration into the epidural space, just about the affected area, and I have stopped using it now. Facet joint injections, I have no experience. The spine surgeons give, it is more of diagnostic, and if they give local anesthetic, then they give, if it confirms, then they proceed with a long effective anesthetic. Likewise, they give into the foramen also. These all require either CR. Some institutes also do CT guided foramen injections also. What about, this is the last one, sodium, this is the latest from the rack, and some institute in South India, especially from Chennai and all, some surgeons are working on that. There is no evidence, not even level 5 evidence. You know, there are levels of evidence, level 1, 2, 3, 4, 5, the least being level 5, the top being level 1. We always, when we speak about evidence, it's always level 1 and level 2. So here level 4 or level 5 evidence also not established. I have tried in one patient, he had immediate relief, but then he came back within 3 or 4 days with pain. This is a temporary, I would say. You give some local anesthetic distal to the, you don't touch the spine here. Like for example, you give around ankle or around knee joint an injection. So maybe in the coming years, we'll get to know more about this. If that really has good evidence, I think that would be one of the best methods to treat radiating pain or radiculopathy. Red flag, I was repeatedly telling 3% of the low backache. Maybe that is the reason we have 3% of them land up in surgery. Any backache, fever and chills. Of course, forget about fever and chills at this COVID season. We are not talking about that, and it was scary to talk about it. But I'm telling you, in your regular practice of backache patient presenting fever and chills, unexplained weight loss, persistent night pain, even whilst lying down, these are the red flags. There may be, and if the patient is immunocompromised, and if he has had recent bacterial infection and history of tumor elsewhere, because secondary tumors are more common in the back. And if he's of younger age and continuously having backache, don't wait. Immediately investigate him, and maybe it's better to refer him to dedicated spine surgeon, because like I say, cardiac venous syndrome is a serious neurologic condition which there is acute loss of function of the lumbar plexus, which affects the bowel and bladder. So we cannot wait here. We have to immediately investigate and treat him with surgery or whatever. So surgery is only indicated if the pain is more than 3 months, or if it is increasing by nature, if the muscle weakness is also increasing, if there is a cardiac venous syndrome, any of the red flags like what I mentioned in the previous. So then only. So briefly, in one slide, of course, you have to do surgery without MRI. You cannot, because without knowing the inside story of that spine and the spinal canal, you cannot undertake surgery. Definitely, MRI is done. The spine surgery is not a small job. It is a big surgery. So what are surgical options we have? Open discectomy. This is what I was used to. I am used to. I knew about. That is, I used to do laminectomy and disc release. Nowadays, the spine surgeons are doing minimal invasive surgeries like fenestration, where they make hole in the lamina and decompress the disc or the compressing material, microdiscectomy with a small incision, endoscopic, which is not recommended, FDA has not approved, So, but some of the spine surgeons claim that is superior to any other form of. All of them end up with doing discectomy, whether it is percutaneous, only through the skin, whatever it is, just pulling out through the rongers. Some of the times, if there is multiple disc involvement and if the lamina is removed, they may require stabilization by instrumentation, posterior instrumentation. So we knew about the risks factors of the causative factors, isn't it? So I would always tell my patients, I take about 10 to 15 minutes. I give them 1 day extra to come for my consultation, and I counsel them about, after they get about 75% of relief. If they are smokers, I ask them to stop cigarette smoking, because we have good evidence that cigarette smoking will cause degeneration of the disc and also the vertebra. Exercise regularly. When I say exercise, most of them jump out and tell, doctor, I do exercise at my park, at gym. No, 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 no. We are not talking about those exercises. The exercise which is related to the back, to strengthen the back, to improve the muscles of the back, which protects, which stabilizes the spine. Yoga, I do not know. I do a little bit of yoga, but I'm not a proponent of yoga in my treatment itinerary. But one of my friends, Dr. Vidyadhar, he has a good article or paper on yoga. He has done a study where yoga is found to be very useful in preventing backache. Good posture while sitting and standing and sleeping is very, very important. And I always advise them, if your job is requiring sitting for a long time, take a break every 1 hour, walk around, come back and sit. And standing, you should avoid, and careful while bending forward or lifting weight. Some of the simple postures for those who are not accustomed to advising like this. This is the best way of advising sleeping. Don't worry about the moment I tell them about, no, no, doctor, I sleep on the floor. No, 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 no. You don't need such punishment. You don't have to sleep on the floor. Beat that. What you need is a firm mattress, maybe not very old. That is enough, and not a very thick pillow. Don't sleep without pillow also. No, no, no. All that is wrong. All that is, your spine should be relaxed. Best way of relaxing, in my opinion, is bending hip and knee and a pillow in between. Or you are accustomed to sleep straight, then let the hip and knee be bent with the pillow support below the knee. Sitting, it has to be straight with the back support. If there is no back support, you have to sit like not slouching, like it is very dangerous, like I showed in graph of that postures. Standing also, it has to be erect. Try to, we cannot do that always, but if you inculcate the habit, because this is called the neutral axis of the spine. The neutral axis of the spine should be from the center of the shoulder, from the neck, from the ear, from here it should go. But in poor posture, which is very bad, this is relatively bad, if the central neutral axis is disturbed. And I get many patients whose job requires prolonged standing. My advice is carry a wooden log, or in your office, find a stool, small stool. If you have to stand for a long time, use that stool and keep one of the legs alternatively for about half an hour or something like, or 10 minutes or 15 minutes. It is said by evidence also, standing for more than 15 minutes continuously every time and time is wrong for the back. So if you have to, unfortunately, or your job requires to do so, then try to use this position, flexing the knee and hip. By this way, it is good for your back. Sitting, of course, this is the correct way. I think this is what we try to tell in the office lectures when we go for ergonomics class. The eye should be straight or little down, 15 degree to 30 degree. The chin little bit down, and your hand should be rested like this and back supported. This is the correct working posture to avoid. More often, this is for the neck problem, cervical spondylitis. Also sometimes for back. Lifting weight, this is the absolute wrong way of lifting. You have to sit down, flex your hip and knee, pain the spine to be straight, not bent like. I make them do this exercise because I drop the pen, I ask them lift this pen. When they try to bend like this, then I pat on their back and no, no, not this way. And I demonstrate how you should pick the pen up by sitting on the floor and lifting it right. And correct or safest zone is keeping, when carrying the, after lifting it, carrying the weight is between this zone, between the sternum and the pelvis, not lower, not higher. Sorry. And if it is always advisable if another person supports and carries with the spines being straight. Of course, I think you're all used to this. We also do, and most youngsters do, whatever advice we give. But I advise them, I show them this picture. I have in my consultation room all the booklets and leaves of pictures of this, where the upright position, chin down, the mobile should be at this position, not here, to bend down, lift it up and square the angle. So this is one depiction where with all that bad posture which I showed, the nerve can be kinked, and when the posture is corrected, it can be released. So simple. I show them all this picture and make them understand what essentially I am trying. On last picture, I'll tell you, helpful exercise. These are the core stability exercises. This is one of the best exercises I would recommend. Very simple for them to do. The physiotherapist might try to do too many exercises. They do one of the worst things I get to see among my patients is, I ask them when they come for my follow-up, are you doing exercises regularly? Yes, doctor, I do. And I ask them, demonstrate. The moment they jump onto the couch, they start doing rigorously. Wrong. Everything, slow motion, slow, part by part, inch by inch, back stretch, pelvic stretch, camel stretch. It is the camel stretch, this cat stretch. This is the best exercise which can be done for, apart from all this. I think some of these positions are there in the yoga. Maybe that is the reason that surgeon has articulated in his paper saying that yoga helps in prevention. Finally, one of my students is a noted spine surgeon here in Bangalore. So I was asking him another day, okay, you have become a spine surgeon now. How easy to do a spine surgery? He said, sir, I'll send he opened his presentation. He said, I'll show you a slide. And that is what is this. It's an easy operation to do poorly. I'm not substantiating to say that all spine surgeons or all spine surgeries ends with bad result. Definitely, in my 30 years of orthopedic experience, what I have understood is this medical science itself is an unexact science. It's never exact. It can never be 2 + 2. It has to be unexact science, and results are unpredictable. So he said, according to his slide, it is, you will do many surgeries, but still you will ask, did I get it? I don't want to pull on the nerve. I can't see that. Yeah, this is the common thing scenario. So this is the exercise we get to see in those things. McNabb is the front runner of backache, who is pioneer in writing textbook on backache. It is, I picked up from his textbook, very nicely written. It must be remembered with the frequent absence of scientific facts, and treatise on the management of back pain must therefore be regarded as a philosophy, and moreover a philosophy that must be modified to fit the needs of the physicians community. Wow, how beautifully he has articulated it. In conclusion, low back aches are common. In my practice, I said 30 to 40%. 90% of the individuals can get backache at any point of their lifetime. Most of them can be managed, 90% according to me, more than 90% in my experience. Sciatica, which is a syndrome, it's not a condition, needs to be monitored, a symptom which needs to be monitored. It cannot be neglected. If he has a radiculopathy, radiating pain, he needs to be seen a little bit often. Red flags to be identified, which I mentioned in my slide. Lifestyle modification is essential, especially the core stability exercises, which protects the spine. Exercise is the mantra of protecting your spine, and lifestyle modification is very, very essential. And I thank you for patiently listening to my, I see some question and answers. Okay. Any role of steroids? This is Nitin Kumar Gupta. Any role of steroids in acute and if and how many days and which steroid you use and dose and duration, please? Yes, I used to use methylprednisolone. I have stopped using. I don't use steroids at all. If at all it is used, I used to use 8 milligram BD and bring it down to 8 milligram OD, then 4 milligram OD, then stop it. Do you want me to type the answer, or is it enough if I answer it? Okay, age 68 with regular workout, walking, ground exercise like leg raising, cycling, lying down, get stiffness and pain in the back while getting up morning. After some moment it subsides. May I continue with workouts remedy? Definitely. This is a beautiful question here. Say you lying down, that is you get stiffness and pain in the back while getting up in the morning. Your sleeping posture is wrong, or your mattress is at question. It must be wrong. So either you have to change the mattress or switch sleeping position. Then definitely ground exercise, leg raising or cycling is the best. Continue with that. Get your osteoporotic level, because you are 68-year-old. Better to have the bone densitometry done and treat that also, because osteoporosis, like I mentioned, is one of the causes of pain, which is common, like getting up in the morning. Any role of LS belt? I just mentioned, Dr. Gupta, I just told the evidence says no. They say don't use it. It is detrimental. In my practice, I recommend using only for the high-end, high-demand patients or very elderly with osteoporotic patients, for two reasons. One, for a sense of stability while doing extreme movements, but I never recommend them to wear it continuously. Only periodically I would address them to wear whenever it is required, not to get addicted to that. How many days you conservatively man the patient before advising surgery? I told you very clearly, I look for the red signs, red flag. If there are any red flags, definitely I'm going to advocate MRI scanning and definitely find out the cause, then pushing for surgery if it's required. Before that, I give them trial dose of injections. If it settles, if it is also helps as a diagnostic. I'm happy with that. If not, so roughly I would say 6 weeks I wait. If there is no improvement by 6 weeks, my word of improvement is nearly 60 to 70% of relief from pain, and stiffness is reduced to almost nil. So in that cases, I wouldn't what is the next question? In epidural injection, which formula you used and image intensifier or blind? Yes, most of my epidural injection, I have taken the help of the anesthetist, and I always used methylprednisolone, and that is the formula which I have used with saline preparation. Please share exercise chart on screen. I think I just showed the exercise chart. I told you, camel stretch, cat stretch are the best one, and floor exercise, lying down and cycling, or that something called sarpasana type, where you lie flat and extend your back, chest up or leg up. Those are the exercises, or simple exercise, lying down, stretching the back, cycling in the air, cat stretch, camel stretch. These are the simple exercise, and side rotations, which I showed me. I can put that back after this talk. I'll go back to that. Do you want me to go back? Oh, no. No, I can't go back.
You can answer a few more questions and then go back.
Yeah. So exercise chart, we can go back. I couldn't go back there. Does the osteoporotic patient also have to follow same exercise? A good question here, Dr. Ayub. Uh, osteoporotic patient, one of the reasons of osteoporosis is lack of exercises. You should understand that. So lack of exercise resulting in osteoporosis, or is there any other reason why that osteoporosis? Then if the reason is for want of exercise, and what we know only localized to back, then there is definitely the exercise uh, is the cause. But same exercise, I would advise not to stretch that forward bending, except that all other back stretch exercises are good enough. How long we should prescribe NSAIDs? Again, good question. Of course, you have to look into the comorbidity of that patient. If he's a diabetic, I avoid any of the NSAIDs, uh, hardly 3 or 4 days. If still having pain and has the comorbidity of diabetes, then I would go with tramadol or combination of tramadol. None of the NSAIDs I would use. Definitely thiacolchicoside is safe. I would say 10 to 15 days of maximum of whether it is opioids or NSAIDs I would use. And like I said, the physiotherapy, that is exercise, and followed by topical applicants would be more than enough. Then what is the... Is selective COX-2 inhibitor is better than NSAID for low backache? In my opinion, I used to use a lot of these COX-2 inhibitors. I don't know. I'm not happy with COX-2 inhibitors. Definitely, I would prefer NSAIDs than, it may differ in others' opinion. It was big time when COX-2 inhibitors were introduced some time back. Celecoxib or something like that I used to use, but I don't know, maybe it has a safety profile, but efficacy is a little bit questionable when compared to NSAIDs. So NSAIDs for low period, 3 to 4 days or 5 days, maximum 7 days, is better than a celecoxib or COX-2 inhibitor which you put up for weeks together. Any other question here?
Questions on the top, Dr. Shabbir and Dr. Kiran Seth. We missed.
No, I don't see any questions further.
No, on the top we missed 2 questions. Dr. Shabbir, Dr. Kiran Seth. Go back when you go up, sir. After Dr. Nitin Kumar, there are 2 questions. Dr. Shabbir, Dr. Kiran Seth.
Yeah, they shows 11 question. Nitin Kumar, how many days I did say that?
Another one, maximum duration of prevalent nortriptyline. Another one is Dr. Kiran Seth. Rheumatology should be involved for inflammatory LBA.
Sorry, I'm not able to see in my screen.
Yeah, I repeat the question, Doctor. Dr. Kiran Seth asking.
Yeah, you can be a little bit louder. I can't hear you clearly.
Dr. Kiran Seth is asking.
Yeah.
Do you think rheumatologists should be involved for inflammatory LBA?
Do you?
Do you think rheumatologists should be involved for inflammatory LBA?
Good question. Rheumatologists may have to be involved if you finally diagnose it to be a inflammatory condition like ankylosing spondylitis or rheumatoid arthritis. Very rarely you get rheumatoid arthritis. Cervical spondylitis is common in rheumatoid arthritis, but lumbar and thoracic is very rare. But if it is of any spondyloarthropathy, then I would recommend, because nowadays it is an era of using biologicals rather than DMRDs. So earlier treatment, I myself have a study done on biologicals used on ankylosing spondylitis, 19 patients treated with etanercept. I did treat them along with the help of another rheumatologist. So there may be a scope for rheumatologists if you are confirmed that it is a case of ankylosing spondylitis or related to that like spondyloarthropathies. Then definitely it is worthwhile to take the opinion or refer the patient for the only reason because early intervention, aggressive treatment by biologicals have given fantastic results in ankylosing spondylitis. Next question.
Dr. Shabbir is asking, what is the maximum duration we can prescribe pregabalin nortriptyline combination low back pain?
One thing is, I avoid nortriptyline. If you ask me if I have to give better antidepressant, I would go for safer one. Nortriptyline has been little too harsh on patients, especially the female patients, they get knocked down easily and they complain whenever they come back. So if I have to definitely use nortriptyline along with pregabalin, then I caution them with all the complications, and I use only pregabalin for a period of 15 to 30 days, depending on the severity of the complaint. Nortriptyline combination I avoid. I might have used in few patients. If at all I use nortriptyline, it would be only 5 to 6 days. That's all.
So there are two questions in the chat box. Can back pain lead to knee pain?
Where is that? So
Can
no,
back pain?
I'm not able to.
Chat box. You will have to see the chat box, doctor. There are two
Chat
questions.
box. Okay, okay.
They are
Where is
posted in the
that? I'll
chat.
go to the chat box. Okay, okay. Yeah, I saw that. Can we turn from side to side while standing as form of exercise? Arti Sabhani. This is from. I told you very clearly, your spine has some movement which is meant for. For example, lumbar spine, though rotation is possible there, forward bending and rotation is very dangerous. So when you're standing upright, turning side to side, that is rotation is okay, but bending forward and turning, twisting is definitely avoided, should be avoided. This is the first and foremost warning I give to my patient, and they follow it well. So from the point of your question, you can turn from side to side while standing as form of exercise. Good, but bending forward should be avoided, not even a little bit of bending forward. And Dr. Lokana the Rao, all cytokines are not neutralized by NSAIDs. Then what is the option? Well, the title of my talk is very clear. I told you very clearly, we are not very sure whether this pain is nociceptive pain or neuropathic pain. Why do I say pregabalin works better? So better in the sense, in my experience, because I have found it to be neuropathic pain. So the radiating pain, maybe the localized pain, then you talk about that cytokine reactions. So maybe if it is not neutralized by NSAIDs, I don't see any further. Steroid may be one of the options, but no, in my opinion, that is good enough. Can you repeat the name of the antidepressant and muscle relaxant for middle age to main age? We will be getting copy of this recording, please. It's very useful. Antidepressant is the latest one they're using is nortriptyline, which is quite good, but why I don't use them is the reason being it is quite heavy on the patient. So I don't use nortriptyline only for, but it is a good and safe in other versions like complications compared to muscle relaxant. I definitely watch for thiocolchicoside, definitely 8 milligram. It comes in both 4 milligram and 8 milligram. I would say 8 milligram in the acute phase of pain. When the patient comes with typical history of injury or trauma, then definitely the muscle relaxant should be 8 milligram BD. If not, it can be OD. If continuation for about 10 to 12 days, OD is enough. Patient with back pain is limping. Would you advise MRI? No, I wouldn't advise. If the patient walks to my consultation chamber by limping, obviously there may be muscle spasm down from the erector spinae to the gluteal muscles, or maybe the spinal root is irritated there. So I don't have to do, because my MRI is not diagnostic for the first appearance of that symptom. After giving some, examining him, finding out whether SLRT is positive, whether the root tests are positive, sensory tests are positive, then I take a decision. And if there are any red flag, then only I ask for MRI. Not in my practice, I will advise, even if he comes with severe pain, I will never ever advise MRI on the first day, unless the red flags like fever, continuous pain, or something like that, then only. Limping is not the cause. Can you spell the name of the relaxant? Oh, it's a tough question to me because I might spell it wrong. Thiocolchicoside, THIOCOLCH colchicoside, SIDE, Thio. It comes in several brands. I don't know, Vasant, do you have muscle relaxant in your?
It's Dolovin TC, sir.
Which one?
Dolovin TC.
Okay. What does it contain?
Aciclovir with thiacolchicoside.
Oh, very good. Yes, yes, I used it. Yes. Your voice is a little faint, Vasant. I'm not really. It is Dolovin TC, definitely.
Yes.
Dolovin TC is a very good, like I said, aciclovir is one of my favorite NSAIDs, though I do use sometimes etodolac. Very rarely I use etoricoxib, but somebody asked about coxibs, correct. But aciclovir is good. Dolovin TC is quite good, 4 milligram and 8 milligram, like I was mentioning. In acute cases, I would, but because it's a combination, you may have to go with 4 or 8 milligram. Kalpana, not all. When to start spinal X after the pain relief? Very good question, Dr. Kalpana, because exercise is the mainstay of the treatment. In my case, in my experience, I have treated all the patients. Why do you do the exercise now? The patient should not come back to you unless you want some fees from him. Repeatedly come back and pay the fees. If you don't want to, if you want him to be better, the exercise. So when do you start? In my cases, if this is not a radiculopathy, if it is not the pain radiating towards the leg and ankle, it's only simple back, I will start the exercise as early as 6th or 7th day, because he would have got the relief by 5 or 6 days. If the relief is 60 to 70%, the spasm is down. You cannot put the patient into exercise when the muscle spasm is down. That is the mantra. If there is no spasm, then definitely you can put him on exercise. And I will definitely, don't just push the patient to the physiotherapist. That is absolutely wrong. I'm not demeaning any physiotherapists here. They are important and integral part of our orthopedic practice. They are needed in our practice. But then, as seen, I only recommend my set of physiotherapists because they know their limitations. Rigorous movement, some unscientific movements will exaggerate the symptom than the condition. So simple exercise, what I showed in that chart, is enough. Any other question? Vasant, is there any question? Bed rest, how long in acute pain? This is again asked by Dr. Kalpana. Oh, I think I missed this point. Dr. Kalpana, there is absolutely no scope for bed rest. That are all gone. If you had asked me this question about 15 years back, I would have said definitely bed rest for a week's time or 10 days. Acute pain, acute spasm with some cause of injury, bed rest is advocated. That too at the most 2 to 3 days. In my treatment chart, bed rest is only for 2 to 3 days. That is only to make the patient comfort, not to treat the cause, and not more than 2 to 3 days. How many days bed rest? I think that I have answered. Pregabalin safety in pregnancy, not safe. No, not safe. No, I don't use it in Vasant. Neurator is not recommended in pregnant women, correct?
Doctor, not recommended.
Yes, yes. I don't use at all. When you finally resort to surgery, when I finally resort, I told you, Dr. Loganathan, I stopped operating because I'm an old timer. I used to do laminectomy. I heard the spine surgeons are back again to the laminectomy, so I may have to restart doing laminectomy surgeries, maybe. But nowadays, foraminotomy or the fenestration technique. So if I have to answer your question, when you finally resort to surgery, red flags, cauda syndrome, tumor, all that red flags signs, even after 3 months, I have not given relief for 50%. I've tried one of those injections. My most favorite injection is epidural spinal steroid injection. If that also doesn't give relief, then definitely surgery. And for your kind information, more often the patient will demand. I think nobody will wait for 3 months. So he might ask me, no, I need surgery, then that way. What is the role of fomentation? I have answered the previous question. When to start after pain relief over?
Previous two you have not answered.
Answered, no?
No. Opinion regarding tolperisol and MRI showing disc extrusion. Two questions we missed.
No, Dr. Purushottam number will be displayed.
Saurabh Agarwal asking what is your opinion regarding tolperisol?
No, the tolperisol, no. If you ask me, no. I used it extensively 10 years back when it was launched. It was we had a speaker from Japan. I think Vasant, if I'm wrong, which pharma was the first one? Don't tell it was you. It was Micro who got tolperisol on the roll here in India. No.
Yes.
Was it Micro? I'm sorry then. So I'm really informed about you.
Some other.
Some other. So they got these Japanese speakers and we were quite impressed. We started using. No, I did not have desired effect. I'm quite happy, except for this. Some patients complain of little bit of drowsiness with thiacolchicoside. Many of them complain about gastrointestinal disturbance. Little bit. They get used to it by second day or third day. So no big deal there. I think quite good there. So what is that? Posterior question. Where is that?
Claudication pain persists after 3 months.
What is the role of, sorry, I'll go back to that. What is the role of fomentation? What is the role of a short-wave dietary patient? All these are, see, fomentation is superficial heat. Short-wave diathermy and interferential therapy, IFT, they are all deep heat. So deep heat is good for the deep tissue relaxation. But fomentation has a role, definitely has a role. I advise most of the time after applicants like rubificients, like I have my favorite brand. I don't know whether I have to tell it here. So when I apply on that back, I ask them to wait for 10 to 15 minutes, then give light fomentation because they should not end up with branding of their back. So light fomentation is one which is recommended after application. What is that? A female patient complains backache last 2 months, family histories. Motor neuron disease, should we go for rule out MND? Of course. Did I miss that? Definitely, doctor, you have pointed out a good point here. Yes, if there is any, I think I mentioned about history of tumor. So motor neuron disease history is there. Definitely, you have to evaluate. A neurophysician is a better person to evaluate it. One worry for you all is to lose your patient. The moment you refer to somebody, you lose the patient. But a history of MND, which we know, it can be a hereditary possibility there. So better to refer and rule out, definitely. There are case reports of seizures with thiacol. I've heard about it, but I've never seen. I've used thiacolchicoside last 10 years, maybe. Myoryl was the first one to come into picture. Now I'm using this Dolovin and other thing. No, not. I have not come across any such. No. What is that? Thio is reliable molecule. Yes, definitely. I agree with you. Best steroid to be prescribed in initial. Ayub, I am a strong opponent of steroid use. I don't like steroid at all. If you ask me, steroid injection is the only thing which I used to give. Of course, these days, deflacortisone is a good steroid, low dose, long-acting steroid that can be given. But if you ask me, no, I don't use steroid to low back. No, zero in my practice. There is something called Medrol pack. If you Google out, you will find out Medrol pack. What is it? It's the combination of steroid drugs. I don't advise at all. Next. Are we done with the questions?
I think we are done with the questions, doctor.
Yeah. So I hope I have clarified most of your doubts.
Yes,
Good
thank
to
you,
know.
doctor. Thank you very much for sparing a valuable time, and thank you everybody for attending.
Thank you. It was a pleasurable evening that I had with all of you. I hope I made my points clear, and uh, please, on the record, this is my experience, what I have quoted and I have shared with you, not to be quoted as an evidence, and most of it are evidence backed. Few of the things may be contrary to what evidence says. So thank you all. Hope to see you or interact with you again in shorter time. I have some few new messages.
No, thank you messages.
Yeah, okay. Thank you, Vasant.
Thank you, doctor. Thank you so
Okay,
much.
bye.
Thank you.